so I'm here with Mike Reinold today, and we're going to have a chat to Mike about the shoulder and a few other things. So I don't think we've actually ever met in person. We've talked via the email a lot and had a lot of conversations, but we've never met in person. So this is the first time that I'm having a face-to-face chat with Mike today. So Mike, I was wondering if you could, thanks for joining us first of all, and maybe you can start by just introducing yourself to everyone that might not know you.
Sure, yeah. And likewise, yeah, we've been talking for several years now, I think, going back and forth. Obviously, have a great deal of respect for what you're building over there with all your different websites and great resources for the profession. So, thanks and thanks for having me. I think this is, it's an honor to be involved with such a great group of people. So, thanks. So, myself, I'm a physical therapist. I'm also an athletic trainer and a certified strength and conditioning coach in the United States, based out of Boston, Massachusetts. So I work primarily as a physical therapist, but essentially what we've done is we've opened up a physical therapy and performance center where we integrate the two and put it together. And really what we're doing is we're trying to work with people that are trying to get the most out of their bodies. So they're trying to optimize themselves. It's funny, we started doing that for the professional athlete model, and I think that's the one that everybody gets, where they get the best combination of multiple domains of profession that kind of come together and collaborate to help them optimize their athletic performance. But why wouldn't we do that for everybody, right? You want to have optimal performance too. So maybe your performance is a little different than somebody that plays a professional sport, but really it should be the same thing. So. Um, Right, absolutely. So and you know what? I mean, I have a lot of amateur people that want even more out of their body than some of the professional athletes that I work with. So, so what we're trying to do is actually just put that integrated system together. So, we started our practice. It's called Champion Physical Therapy and Performance in Boston, and it's really where we kind of blend our physical therapy and manual therapy techniques and our performance and fitness concepts into one big package.
Cool. And so tell me, were you a physical therapist first or an athletic trainer first?
So I went to physical therapy school. It's actually a long story, but I went to physical therapy school. But this was back in the '90s when we actually we had the ability to become an athletic trainer because we took so many of the same classes. So we just had to take any classes that we missed and then do a lot of hours. I think I had to do like 1,500 hours in an athletic training situation and then sit for the board. So that route no longer exists to get certified that way, but you could do that 20 years ago. I was a physical therapist, and then in tandem was kind of working to become an athletic trainer at the same time.
That's quite interesting. So the athletic training was part of your physical therapy education package.
There's just a lot of overlap between the two professions. So I had to take, I think I took two extra classes. That's it. So in our in our PT curriculum, it was essentially, some more, but different. And then we took like I literally had to take like intro to athletic training and the basics to cover the first aid, the emergency response, the stuff that the physical therapists and the physios don't do as much, as the acute, how do you handle something that happens right away and really triage the medical emergency and figure out what to do.
So that's quite interesting, and I know we're not here to talk about this today, but it's just interesting because in the UK, some of the universities are just integrating an exercise qualification into their physiotherapy degree, which is interesting. So it sounds
Yeah.
similar to what you went through, which isn't available to you guys now, but it sounds like that sort of thing's coming in the UK now. So interesting.
Yeah.
But we're here to talk a little bit about the shoulder, and we were just talking before we started recording that you sometimes we get pigeonholed into being specialists in some areas, and you seem to have been pigeonholed into the shoulder specialty, despite the fact that you treat individuals with any kind of injury or complaint. So, and certainly I know you as a bit of a shoulder person, but which is why I've contacted you today. So, how did you become pigeonholed as a shoulder person?
I guess I guess it just comes down to what you, I think what you like and what you're passionate about, and then the group of people that you tend to work with the most. So I work with a lot of overhead athletes and baseball pitchers, specifically, but a lot of overhead athletes. So obviously they're upper extremity injury based things, and you end up using kind of the same skill sets that you use, for that population on several other people. So I guess when you just like a certain topic, you tend to write more about it, you tend to publish more about it, you tend to speak more about it. And it's funny, at some point in your career, and this happened, I don't know, at some point in my career this happened, but people would like literally say, they'd be working with you for 4 months on some issue, and then they'd be like, yeah, do you know anyone that could help me with my knee? And I'm like, no, have no idea. The knee's confusing, like, so it's funny, but yeah, I guess that's how you get pigeonholed. But you get known for treating certain populations. So for me, it's part of the overhead athletes, and obviously shoulders are the number one thing for them. So I guess that's how I got pigeonholed, and obviously publishing so much on shoulder related issues.
Sure, sure. So, what are the most common shoulder conditions? Let's stick with the shoulder. What are the most common conditions that you see?
So again, I guess I'd say still my greatest population of people that I see are overhead athletes, excuse me. So what I tend to see in the overhead athlete population is, honestly, it's usually just a combination of cumulative eccentric trauma from throwing, because throwing's not good for you. So once we get that out of the way, that's like our first educational step with all our clients is, they say like, hey, I don't know why my shoulder hurts, and I say like, I do. It's because you throw baseball for a living. It's that simple. It's not, there's really not much more behind it there. So other than stopping from throwing a baseball, what can you do? But for overhead athletes, they tend to present with a lot of fatigue and then a lot of micro trauma to the rotator cuff. So the rotator cuff just doesn't function well. So you have an inherently loose population. So they have congenital laxity probably already with their joints, which kind of predisposes them to be able to be baseball players to begin with, or overhead athletes in general. So this could be tennis, volleyball, football quarterbacks. I'm trying to think of what you guys do over there that we might be different. Cricket, you guys cricket players? Is that, yeah, handball, right? That's another one, I think. Water polo, but anything where you're using your arm overhead, you essentially you tend to have this inherent inability to have static stability of your shoulder. So you have to have pristine dynamic stability, and nobody does. So that's what I tend to see. Now, diagnosis wise, if you want to talk diagnosis, I guess we see like a lot of internal impingement. So not articular sided subacromial or bursal sided impingement, but more internal impingement where the undersurface of the rotator cuff impinges on the superior glenoid within the joint. So and again, that has to do with the same mechanism. It has to do with micro instability. So you get some sort of anterior translation of the joint, and then your rotator cuff on the inside chafes on your glenoid as you slide anteriorly. So again, it's yes, do you have a slap tear? Yes, do you have internal impingement? But what you really have is micro instability. So you still have to work on dynamic stability of the shoulder. So, it's weird. I mean, I've actually stopped diagnosing, or I shouldn't say that, that sounds weird, but the emphasis hasn't been on diagnosis as much because I don't want anybody to have surgery. I mean, the second we say diagnosis, we get closer to having a surgery, at least here in the States. You say the word slap and then you start thinking anchors everywhere, and that's kind of what tends to happen. So for us, we want to try to avoid that, because once you start putting a stabilization procedure on somebody that needs that mobility, their livelihood's at risk.
So, what kind of techniques, what kind of management programs, what things do you use to help these people?
Well, I mean, I think, even if we take it outside of just the overhead athlete population, we just talk about everybody in general. If you focus on what they need versus what their diagnosis is, I think oftentimes that will lead your treatment progressions a little bit more. So, talking about a few other populations, I would say, the CrossFit world is very big with us here in the States, and I think it's getting bigger internationally as well. But, CrossFit, nothing wrong with CrossFit. It's just the exercises they choose tend to be stressful on the shoulder for various reasons. So, you can say what you want about it. I'm CrossFit friendly, but they tend to choose exercises that need a lot of overhead mobility and overhead stabilization and clean mobility. But the problem is that population and even the sedentary office worker. Like, so if we really talk about the spectrum of people here, that they tend to lose the proper amount of mobility. So, what I tend to see in most of my people is that they've lost overhead elevation, probably as one of their, key indicators that I see is they lost overhead elevation. And again, that could be capsular, that could be soft tissue, that just could be alignment and positioning with their thorax and their scapular positioning. But they've lost the ability to go all the way overhead, yet they choose to do things during the day that require overhead mobility. So I ask them what they do, and then they show me, like, maybe they're overhead squatting or they're snatching or they're doing something on a pull-up bar, and then I ask them to just elevate their arm, and when they have 150 degrees of elevation, I ask them, well, how do you think that happens? Like, there's a disconnect here. How are you getting to that position? There has to be a path of least resistance and something that's taken a beating here, and it tends to be the shoulder. So, getting back to your question that I think you asked like 10 minutes ago now, I think what it comes down to here is that, again, you could say that somebody has impingement or they have rotator cuff, whatever, tendonitis, whatever it may be as a diagnosis. But if you don't improve their movement quality and their ability to use their arm in the position that they want to use it in, you're never going to have a positive effect. You may have like a quick 3-day transient improvement in symptoms, but you're not going to have a long-lasting improvement in their functional outcomes.
So you must tend to do a lot of exercise therapy and stabilization work with them?
Correct. Yeah. So the first thing we do is we work on, in the States at least here, and I apologize if I'm sure you guys are similar, but our educational paths, a lot of people, right? The concept we talk about is it mobility before stability, or some people then argue is maybe it's stability before mobility because maybe the mobility is just a motor control issue. So we have this whole concept, but I always say it's neither. I say it's alignment before mobility before stability. So, for example, let's say you have somebody that's, again, works at a desk all day and have, extreme amount of thoracic. Yeah, we both just sat up on video, which you guys can't see right now. But they have extreme thoracic kyphosis and then anterior tilt of their scaps and protraction. They just have this terrible position, and then they lost overhead elevation. Well, I can hammer the capsule, I can work on the soft tissue of the shoulder all day, but if I don't address their alignment and their thoracic position, their rib cage position, their scap position, then I'm wasting my time. So we work on alignment first. And that just really depends on what it is. That might be manual therapy on the thorax. It might be some rib positioning things. It could be scapular. It could be soft tissue. So we do a lot of manual therapy to get their alignment and then their mobility going. So we do a lot of soft tissue techniques. We do a lot of different ways to help the tissue reduce tone or maybe increase length or decrease the density contractures that may have in there before we start hammering on them. If you go straight into just torquing the joint, oftentimes you're going to stretch what doesn't need to be stretched instead of what really does. And then you've created another issue right there. So you're just jamming them up into shoulder elevation, but that's not their main issue. You're just going to further increase their symptoms because you're increasing mobility in an area that is probably already lax instead of focusing on the right thing. So we'll hammer the mobility. We'll get them in good alignment first. We'll get the mobility going with soft tissue work, and then we'll try to strengthen that new position and try to really increase their positional tolerance there by doing the right exercises that we use a combination of both strengthening and then dynamic stabilization techniques. And again, to me, that's the recipe. It's alignment, mobility, strength, and then stability. That's kind of the four. If you miss one, I think you'll get good outcomes, but you won't get good long-term outcomes.
That's interesting. Really interesting that you're changing it from just stability, mobility, which we do have. We follow that model as well over here, and adding in the alignment and stabilization. I think that's a really nice model. So you've talked a bit about how you prepare the alignment, how you correct the alignment, things like that. When you're moving on to and mobility, obviously using manual therapy techniques, which you've talked about, moving on to the strengthening and stabilization. parts of the management program. What kind of exercises do you find yourself using? What kind of home exercises do you find yourself are commonly given? That sort of thing.
Sure. I'm still a big believer that we need baseline strength. And I think we're getting too fancy in our professions here, and we're starting to confuse the word, I guess, function. We're starting to use that a little bit different here, and there's a trend towards trying to get away from exercises that aren't functional. And to me, I get it. I see that. I think you need to have functional exercises, but I also believe that you have to have baseline strength first. So to me, like for example, side lying external rotation for the shoulder is still one of our primary, efficient exercises that we do because everybody's weak in that pattern. So we have to increase their external rotation, their posterior cuff strength. And if I jumped right to a functional activity, the brain, the motor control pattern, the neuromuscular control of that is all it's too much for that to handle right there. I can't use the shoulder in a functional pattern if it doesn't have the baseline strength yet. Or I can, but it's going to take that path of least resistance again that we talked about earlier and develop some compensatory patterns that we don't want. So to me, I want baseline strength first. And I think we've skipped that step lately in the last kind of generation of people coming out. The new grads coming out, I'll preface this, I guess, with saying no offense, and then add they really need to get better. But the new grads coming out are so worried about all these techniques and these advanced things. They're all going through, PRI certifications, DNS certifications, using the FMS system. All that stuff's great, but they have no idea how to treat a shoulder. So they're focusing too much on like the icing and not on the cake. They need to, get that baseline first. So for me, we have to establish baseline strength because a weak muscle can't stabilize. So, once we get that baseline strength going with just, again, the plain, boring isotonic exercises that you may use that are designed for a specific reason. So, we've researched all these exercises like the prone exercises for scap control and the rotator cuff. We've done that for a reason. We're not just looking for the exercises that get the highest amount of rotator cuff or scapula EMG, but also the ratios that we're looking for. So maybe something that gets a lot of low trap and reduces the amount of upper trap activity, for example, if that's what we're looking for. So we have to kind of groove that pattern by getting a little stronger first, and then we transition to the more functional patterns over time. So I think a lot of people, again, just jump right to the functional pattern because it's cool, it looks better on YouTube, and they just want to kind of get there faster in that position. But when, again, you don't have that baseline strength, you're going to probably use some poor movement pattern to get there because the brain and the human body is really, really good at tricking us and getting from point A to point B. So it's going to get to point B. It's our job to make sure it gets there as efficiently as possible.
I think that's really good advice. I think that's really excellent advice. Just taking us back to basics, I think in physiotherapy, it's a progressing profession. We're taking on a lot of new techniques and extended sort of scope, but taking us right back down to basics and just telling us that we need to do the basic exercises as well. And yes, they're boring, and yes, they become easy after you learn them all and things. But everybody needs them. Everybody needs them to give them a strong joint to base their movement from.
Right, right. And I totally, I should say too, it's not that, you also have to be careful not to just get stuck in that phase too, which is another common error in the physical therapy field, I think, is there is a next progression to that. So for me, I jump to the functional stage rather quickly, but I don't skip steps. I think that's the important concept. And, people aren't paying me to watch them do side-lying external rotation. So we don't do that a lot with me, but I may do it with my manual resistance so I can feel their strength. I can feel their improvement. I can feel how smooth they are. I can feel if there's some jerkiness. I can add some rhythmic stabilizations to the technique to kind of just see how well they're stabilizing. So there's ways to do it, but you have to have the basics, but you also then have to have the progression as well. So I don't want to come across as saying you don't want the advanced stuff. You do, and you need that stuff, but you definitely you have to make sure you're getting the basics as well.
Yeah, absolutely. And so, what are your favorite functional exercises for the shoulder?
Well, so I guess I don't know, it's such a broad topic, I guess. Yeah, no, I like it. That's what you do. I like it. Um, I think function to everybody means something different. So my functional exercise depends on the person. So oftentimes it's just using the extremity in the position that they're going to be using it all day because we often exercise in mid-range motion or safe areas, right? You have to then exercise in maybe disadvantageous areas, but if that's going to be their functional area, you're going to get there. So, depending on what you do, I try to simulate some of those movements and patterns that you'll do during your activity, whether it be work or sport or whatever it may be. We try to simulate that a little bit. In general, obviously, going back to basics, even with just like PNF patterns with D2 and D1 patterns. I tend to use D2 more than D1, but using the PNF based patterns, I think if you don't fully have a good, if you don't have like a good functional goal for your person right there in front of you, I think you could use stuff like D2 PNF patterns. I think are very applicable for the shoulder. I think that's a pretty functional activity, but again, it's not just doing that on the table. It's maybe getting them in different positions. So we may start that supine. We might do that tall kneeling. We'll progress to half kneeling. They might do it in a split squat position. So it really just depends on getting them where they are. But it's not just the shoulder. It's getting their body in that functional position too. So, they have to be able to control their thorax, their lumbopelvic area, and have good stabilization there while they're performing their upper extremity tasks for them to truly, call it a functional task.
And yeah, and that's where it's important that you need that other person who's the expert in the knee to come along and help you.
Yeah, it's fantastic. I do a talk on corrective exercises, and I did a Google search for that, and I showed like the top 5 pictures that come up for corrective exercises, and they all require a stability ball. So it's funny. It's like Google thinks that a corrective exercise you must have a stability ball. So it's like doing it's like doing bench press while lying on a physio ball, which is rather insane and probably quite a bit of a liability concern if that ball ever pops. But it's not about just throwing a big Swiss ball underneath someone and calling that a functional exercise. It has to be functional to them. So unless you do a horizontal pressing movement on an unstable surface for a living, then that's not a very functional exercise for you.
Nice. So it's important to really get to know what's important to your patients, isn't it, or to the individual that you're treating?
Exactly. They're not paying you to force feed evidence-based treatment down their throat. They're paying you to feel better and move better.
Yeah, nice. So I'm aware that we've only got a few more minutes left because we had a bit of a problem with the time zones here. So just quickly, just to finish on how have you seen like progression in coming to the evidence, in the research, in the management of shoulders over the last 4, 5, 10 years?
Yeah, I still think shoulder, for whatever reason, has probably been the most heavily researched over the last, I don't know, 4 decades even. If you really think about like where we are with hips as a good example right now, hips are where shoulders were almost in the 80s. When they started doing scopes in the shoulder in the 80s, we're starting to do scopes more now in the 2000s and 2010s, I guess. So shoulder's been, it's probably because people like the shoulder more. It's, people injure the shoulder more, but our evolution of the shoulder continues to evolve over time. What I've started doing with my personal practice is just get more specific to certain niches. And what I'm finding with shoulders is that you really can't compare, 2 different populations and try to have an established norm for everybody in the world. So the baseball player concept is where we, often draw that conclusion from because they're such anomalies. They're the outliers. So they have adaptations to their shoulder that are very specific to what they do for a living. So if you don't understand that, and if you don't understand the specific adaptations to the activity that you're doing, you're going to treat them wrong. So the example with the overhead athlete then obviously is just on their throwing side, they tend to gain more external rotation and they have a subsequent loss of internal rotation. So you can see this really on anyone that throws. So on myself, I have that same limitation, but it's uncanny that the total rotational range of motion is similar. So in the past, 10, 15 years ago, we just said, oh, wow, everybody that's injured has a loss of internal rotation. But what we're finding is like, oh, everyone that's not injured also has a loss of internal rotation. So that's an adaptation to it. So we spent a decade really torquing everybody into internal rotation, and I think that made everybody worse. So, so what I'm trying to do in terms of research and trying to, help with that is to establish that there's different norms for different people based on their adaptations. So, you can't treat everybody the same. It's different in that fashion. So I think to me, that's the next wave of research that we're going to start seeing with the shoulder. I think we get the anatomy. I think, it's pretty good. I don't think we're going to find another ligament or anything like that that's just going to magically appear in the shoulder, like
Are
with
you
our
sure?
knowledge of
Because there was one that
that.
appeared in the knee last year.
I remember that. Well, it was new to the media. We'll leave it at that. It was new to the New York Post. But I don't think we're gonna have a big understanding of that. I think the future for us is we're going to start realizing that different people have to use their shoulders in different patterns, and we're going to start having a little bit more unique kind of treatment approaches and evaluation approaches to those specific people. I think to me that's the future, and we're going to see that with all the different joints, but it's not going to be established norms for an entire population. You have to understand the subtle differences between the different ones.
Yeah,
So
nice.
I'd say that's the general. I mean, I think the other area that we still need to get better at is the biceps, though. We don't understand why people get so much biceps pain, and unfortunately, we're starting to do tenodeses more. Where we're just saying like, well, we don't know why it hurts, let's just cut it off, and that's probably, if you write that down on a piece of paper and put it in an envelope, and then in 20 years open up that envelope and be like, oh, that's what we were doing. That sounds weird. We just said it hurts, let's cut it. That's crazy. I don't know. I think we need to get better at that. But that would be the two areas that I say that we should all be kind of working towards.
That's good. That's really great advice. I think I think you need to head off. We're out of time here. So that's been really good to chat to you. That was a really nice, succinct covering of the shoulder. I think that'll be really useful to some people listening. It's been great to talk to you. Now you've mentioned lots of research that you've done and things, and I know you have lots of exercises online. Where can we find you online to find out more about your work and some of the research that you've put out?
And best place for me is just my main website, which is just my name, just MikeReinold.com. I've been writing that for wow. I just started trying to add up the years there. So, but 7, 8 years, and really up until we opened up Champion a year ago, I was doing about 2 articles a week. I slowed down a little bit with Champion there. I'm maybe about one a week, but I've done about almost 2 articles a week for 7, 8 years. So there's lots to do. And you can see the evolution of my writing style as well as you go back pretty deep in there. But lots of great resources there. I mean, a ton of free articles on there. All my educational products are kind of linked through there. So I have a bunch of stuff for the shoulder and overhead athletes and various other things that are on there. But that's essentially my hub, and I won't even give you anything more than that because that'll give you months of stuff to do there. So just go to MikeReinold.com and check it out, and I guess that would be your starting point.
Yeah, I think we can find most of your stuff from there. So, Mike, it's been great to talk to you today. Thank you very much.
Yeah, thanks so much. Thanks for having me. Like I said at the beginning, it's an honor to be involved. Great website. So happy to help the readers and listeners, and hope this was educational for everyone.
Great, thank you. And we'll have you back to talk about the knee next time.
Sounds good. I'll find someone for you.